I am not a news coverage kind of content creator. Rather, it is my aim, or at least hope, to address culture. That being said, in light of recent news stories from the past few months, particularly those involving the homeless and the slaughter of children, I have seen multiple political commentators call for bringing back the state mental hospitals with their coerced psychiatric care, based on the idea that both the homeless and the perpetrators of such violence are mentally ill. I have seen this call even amongst commentators who claim to hold to the non-aggression principle and who claim to speak out against the state and its power. And while I have already talked about coercive psychiatric care at length, this prompted me to take on a topic I have put off exploring, one of the worst mental illnesses that there is, and how the diagnosis and treatment of that supposed illness further highlights the inadequacies and incompetencies, to put it mildly, of the mental health industry, or mental health care, as it is often dubbed. And here I will jump straight into the academic literature. Schizophrenia by Michael J. Owen, Ph.D., Akira Sawa, M.D., and Preben B. Mortensen, Ph.D., from The Lancet, 2016. Schizophrenia is a severe psychiatric disorder that has a profound impact on the individual and society. While outcomes may not be as uniformly negative as is commonly believed, over 50% of those individuals who receive a diagnosis have intermittent but long-term psychiatric problems, and around 20% have chronic symptoms and disability. Unemployment is staggeringly high at 80 to 90%, and life expectancy is reduced by 10 to 20 years. Diagnosis is made clinically on the basis of history and by examination of the mental state. There are no diagnostic tests or biomarkers. As I reiterate intermittently, schizophrenia, just as all other supposed diseases listed in the DSM, does not have any clear biological tests or biological markers, and as such diagnoses are subject to the incredible bias of the psychiatric clinician. As Owen, Sawa, and Mortensen continue, schizophrenia, like the majority of psychiatric diagnoses, remains a syndromic concept. The use of operational criteria, such as those embodied in the Diagnostic or Statistical Manual of the American Psychiatric Association, DSM, or the International Classification of Diseases, ICD, of the World Health Organization, has provided a reliable approach to making psychiatric diagnoses in the clinic. However, the assumption that the clinical syndromes defined in this way represent valid disease entities with distinct underlying etiology and pathogenesis is increasingly seen as having impeded research. Indeed, psychiatric diagnoses have the unusual property of being simultaneously too broad and too narrow. Individuals with a diagnosis of schizophrenia vary greatly in predominant symptoms, response to treatment, course, and outcome. However, attempts to resolve this heterogeneity into valid subtypes has repeatedly failed. Here I would note the importance of reading international or non-American journals, such as The Lancet. The American literature often fails to point out any shortcomings or gaps in professional understanding of the likes of schizophrenia, often enough leaving a skewed picture of the mental health industry, its knowledge, and capabilities. One of the obvious reasons for this dynamic is conflict of interest ties to the pharmaceutical industry. Although it should be added, even the primary author here, Owen, is also listed as having a conflict of interest tie to that same industry. The Pharmacological Treatment of Schizophrenia by Donald C. Goff, M.D., from the Journal of the American Medical Association, JAMA, 2021. Schizophrenia is a chronic psychotic disorder with typical onset in early adulthood and a lifetime prevalence of approximately 1%. In addition to the hallmark symptoms of psychosis, delusions, hallucinations, disordered thinking, that is, the positive symptoms of schizophrenia, as we shall see, individuals may experience negative symptoms, apathy, loss of emotional expression, and cognitive deficits. In the past, people with schizophrenia often were confined lifelong to psychiatric hospitals. However, the introduction of effective antipsychotic drugs, starting with chlorpromazine, Thorazine in 1954, followed by the Federal Community Mental Health Act of 1963, resulted in deinstitutionalization of an estimated 92% of hospitalized patients by 1994. The difference between positive and negative symptoms here is important, especially in relation to pharmacological interventions. But it is also important to address the 2021 reference here to effective antipsychotic drugs, starting with chlorpromazine, thorazine in 1954. Chlorpromazine in the treatment of neuropsychiatric disorders by N. William Winkleman, Jr., MD, again from JAMA, 1954. In the present study, it was observed that, when given parenterally, by injection, and in sufficient doses to psychotic or severely obsessive patients, the drug produced an effect similar to frontal lobotomy. Patients who had been severely agitated, anxious, and belligerent became immobile, wax-like, quiet, relaxed, and emotionally indifferent, unlike persons who had received barbiturates for sedation. They remained responsive when spoken to and could easily be awakened if they fell asleep. The historical context is key. An effect comparable to frontal lobotomy in the 1950s that could produce patients with emotional indifference would have been desirable and sought after at the time. This is what constituted effective treatment. Increased dependency, reducing adult cognitive capacities down to those of a child or infant, even highly dangerous side effects such as jaundice. These ultimately did not matter in light of creating a more manageable patient. But Goff seemingly reflects that view as well, nodding as he does to chlorpromazine, thorazine being an effective treatment. It is also not unimportant that Goff is listed as having conflict of interest ties to the pharmaceutical industry as well. But as Goff continues, although outpatient treatment has been largely successful in allowing people with schizophrenia to live in the community, a shortage of treatment and rehabilitation services and housing, combined with reluctance of some to accept services, has contributed to high rates of homelessness and incarceration among those with schizophrenia in the U.S. After the introduction of chlorpromazine, additional first-generation antipsychotic agents were developed. These agents did not differ in efficacy and were found to share dopamine D2 receptor antagonism in common, along with associated adverse effects of Parkinsonism, akathisia, motor restlessness, tardive dyskinesia, potentially irreversible chloroform movements, and hyperprolactinemia. Is it any wonder then why schizophrenics might be reluctant to accept services or mental health care, perhaps even choosing homelessness, given the nature of these side effects? Parkinsonism, that is, the movement symptoms of Parkinson's disease, tremor, slow movement, rigidity. Akathisia, this is a sense of inner restlessness, an intense feeling of agitation, non-productive, often uncontrollable movements, including rocking, pacing, and shifting weight that do not give relief, and suicidal, homicidal ideation. Tardive dyskinesia, potentially irreversible chloroform movements, that is, problems with coordination, jerking or writhing movements, potentially irreversible. Hyperprolactinemia, that is, high levels of the hormone prolactin in the blood, which can cause infertility, low libido, low bone mass, changes in menstruation in women, erectile dysfunction, and low levels of testosterone in men, and so on. As Goff writes, the lack of options for people who did not respond to first-generation antipsychotic drugs led to the delayed development of clozapine, which was derived in 1958 from the antidepressant imipramine, and subsequently found to have unique antipsychotic efficacy, but was abandoned due to the adverse effect of agranulocytosis, which occurs in about 1% of patients. Agranulocytosis, that is, a life-threatening condition involving severely low levels of white blood cells, reducing the body's ability to fight infection. Clozapine was approved by the U.S. Food and Drug Administration, FDA, in 1990 for treatment-resistant schizophrenia with mandated monitoring of white blood cell counts. Clozapine improves refractory psychosis in up to half of patients, reduces suicidality, and is virtually free of neurologic adverse effects and prolactin elevation. More about these claims in a moment. Because delay in initiating treatment has been associated with poor outcomes, it has been hypothesized that untreated psychosis may have persistent detrimental effects. This hypothesis has not been rigorously tested because placebo-controlled trials of long duration are generally considered to be unethical. Withholding of effective treatment may prolong the discomfort and risks associated with psychosis while potentially worsening long-term outcomes. Again, we see a reference to effective treatment, even in light of such horrifying side effects. And I will come back to this point as well, especially as it relates to ethics. Why do we not use psychosocial interventions in the treatment of schizophrenia? By Anthony Harris and Philip Boyce from the Australian and New Zealand Journal of Psychiatry, 2013. The authors here also list conflict of interest ties to the pharmaceutical industry. The treatment of schizophrenia presents a conundrum. Remarkably, even though we are aware that the major portion of the disability caused by schizophrenia is a result of the negative and cognitive symptoms, the principal focus of treatment has been to reduce the positive symptoms of the disorder. Negative and cognitive symptoms limit the ability of the individual to form relationships, obtain employment, be financially secure, and care for themselves independently. People living with a psychotic illness and those who care for them rate these problems as their major challenges for the coming year. Along with poor physical health, these problems rank ahead of symptomatic treatment and access to specialized services. So notwithstanding the importance of treating negative and cognitive, both neurocognitive and social cognitive symptoms or treatment strategies are still directed towards the short-term pharmacological resolution of positive symptoms. The deficits caused by negative symptoms are little changed by standard antipsychotic medications, including clozapine, dashing earlier hopes that the second-generation antipsychotics would alleviate them. As Owen, Sawa, and Mortensen continue in their article, antipsychotic drugs are relatively effective in reducing positive symptoms, such as auditory hallucinations and delusions, and remain the mainstay of both acute and long-term pharmacological treatment. However, they are not effective for other important clinical features of schizophrenia, such as negative symptoms and cognitive dysfunction, which are more strongly associated with functional impairment than positive symptoms. There is evidence that long-term maintenance treatment with antipsychotic drugs is effective in preventing relapse of psychotic symptoms, but troublesome side effects such as weight gain, movement disorders, and sedation are common and contribute to poor adherence. Moreover, a substantial number of patients show no, or at best partial, response in positive symptoms with current antipsychotic drugs. Individual response is often idiosyncratic and difficult to predict. Newer so-called second-generation antipsychotic drugs can be effective in treating psychotic symptoms with fewer movement disorders, but carry a higher risk of cardiometabolic side effects. In short, schizophrenia can be broken down into positive symptoms, delusions, hallucinations, and disordered thinking, and negative symptoms, apathy, loss of emotional expression, and cognitive deficits. Pharmacological treatment remains the mainstay for both acute and long-term treatment, even though it is only effective in treating these positive symptoms, at the potential high cost of debilitating and even permanent side effects, and is ineffective in treating these negative symptoms, which are more strongly associated with functional impairment than positive symptoms. Given all this, these treatments are also somehow viewed as so effective as to make study of schizophrenic outcomes without their use unethical. Again, such treatments were historically considered effective in that they could be compared to the effects of lobotomy, namely because they created more manageable patients. It does not appear as if we have come much farther in the past several decades. And in the context of our current political environment, this is the kind of mental health care people keep calling for. However, this maiming and permanent damage of the brains and bodies of those we consider problematic seems doubtless to be less of a solution and more of a part of the problem. And what it seems like we might need is an altogether different approach. But I will leave it off there for now, picking up next time with the cultural, environmental, and other factors related to schizophrenia. I hope to see you there.